Hello, my name is Diana Sharafali, and on behalf of Doreen Raby and Robin Holden, I'd like to welcome you to the Methods chapter of Diabetes Canada 2018 Clinical Practice Guidelines. The 2018 chapter for Methods is really built on the 2013 Clinical Practice Guidelines and generally some overarching guiding principles. We sought to create the 2018 guidelines to be rigorous and evidence-based. We also wanted to ensure transparency in the process of finding evidence, the evidence for which the guidelines are based on, and how we evaluated that evidence. We also sought to fulfill the criteria outlined in the Agree To instrument, as well as harmonizing with other guidelines. This process involved multiple steps. Step number 1, developing of clinical questions. Number 2, a centralized literature search that was updated 2 times. Therefore, we had 3 literature searches. A review of the literature from a third party or an evidence center that screened for all relevant citations. Number 4, writing preamble and recommendations. Number 5, a process that included every recommendation to be reviewed and approved by 100% consensus at a steering committee level. Number 6, external review of the guidelines and recommendations at a national and international level. Number 7, a full independent methods review by which independent colleagues across Canada reviewed every single recommendation and the evidence that supported that recommendation. Number 8, final approval by steering. Number 9, publication. And number 10, dissemination and implementation. In terms of how we identified articles, we started by identifying clinically important questions. Questions regarding treatment, prevention, diagnosis, and prognosis. This also included a centralized literature search where the searches were built by librarians trained in health sciences and evidence-based practice. And we systematically conducted literature searches, which included known articles, multiple databases, as well as manual searches of listed citations from other articles. As you can see in this figure, just over 500,000 citations were identified through databases. 400,000 were initially screened, and approximately 8,000 were generated to be reviewed by chapter authors. Of the 8,000, 323 separate citations required new or revised citations or recommendations for this particular guideline. Rating of the evidence included multiple steps. One was we looked at the relevant studies. We formally assigned each a level of evidence. We looked at the highest available evidence or level of evidence. The same standardized approach was used since 2008 as well as 2013, and this comprises a set of rules to rate studies depending on their type of design. More importantly, was it a study of prevention, treatment, diagnosis, or prognosis? Rating was dependent on the study design, but also the strengths and weaknesses of each study. Formulating a recommendation included, what does the evidence say? In other words, what was the recommendation? What is the highest level of evidence? In other words, what is the grade that we would give that particular type of evidence? And number 3, what was the reference or the study that provides that highest level of evidence? Grading recommendations is based on a hierarchical level, grade A to grade D, A being the highest level of evidence or best evidence. And this included level 1 evidence, which comprised high-level RCTs or randomized controlled trials, or systematic reviews or meta-analyses of randomized controlled trials. Grade B or level 2 evidence was considered to be randomized controlled trials, which had some methodological limitations, or systematic reviews or meta-analyses of other types of study designs, other observational studies. Grade C or Level 3 evidence comprised cohort studies, and Grade D or Level 4 evidence was other types of observational studies, case control studies or case series. Grading of the evidence, particularly assigning a grade, also considers our level of confidence in which we are ascribing to that particular evidence or that recommendation. The other thing we tried to stay true to and fulfill was our commitment to the agree-to process, the appraisal of guidelines for research and evaluation. And although this is an instrument for steps outlining appraisal, we actually followed it to ensure that we were covering all of the steps. And this includes identifying the scope and purpose, stakeholder involvement, rigor of development, applicability, and editorial independence. Under scope and purpose, we tried to ensure that our objectives and the purpose of the clinical practice guidelines were specifically described. Clinical questions covered by clinical practice guidelines are specifically described. And finally, patients to whom the clinical practice guidelines apply are specifically described. Under stakeholder involvement, we considered all relevant professional groups to be involved in this process. We also considered patients' views and preferences. Target users of clinical practice guidelines are also clearly stated. And finally, the guideline has been pilot tested among target users before the publication. The rigor of the development included a systematic methods approach used to search and find evidence. There was transparent criteria for selecting the evidence, and that is clearly described. Methods used to formulate recommendations. Health benefits, side effects, and risks were considered as outcomes. Explicit links between supporting evidence and recommendations were outlined. The rigor of the development also included external review prior to publication, as well as a procedure for updating guidelines that are currently in place. Continuing with rigor of development, we also considered the recommendations, that they are specific and unambiguous. Different options for management were presented when available, and key recommendations are easily identifiable, and the CPGs are supported with tools for application and implementation. Finally, applicability. We considered potential organizational barriers, and these were discussed. The potential cost implications were considered when available in the guidelines, and the CPGs offer review criteria for the purpose of monitoring and auditing practice. Editorial independence was considered, as the CPGs are independent of the funding body or bodies. Conflict of interest of guideline development members was recorded and captured at multiple iterations throughout the process. The Independent Methods Review Committee comprised co-methods chairs Doreen Raby and myself, Sonia Battaglia, David Campbell, Derek Hunt, Alexander Leung, Jeffrey Mann, Carrie McBrien, Charlotte McDonald, and Valerie Palda. And thank you to the Independent Methods Review Committee for their expertise and support. The Independent Methods Review Committee was a group of identified methodologists that appraised evidence independently from expert author groups. Their external review ensured that the content is valuable and accurate, and it also ensures a rigorous and risk of bias that is minimized in the interpretation of the evidence and grading of the evidence. IMR reviewed each recommendation at various stages in the development, particularly prior to all steering meetings. An early review was done that was focused on process and wording and drafting of recommendations. A final review was done that focused on the fidelity of the wording with the evidence. In other words, did the recommendation match what the study was actually saying or what the study found? And then the grading of recommendations based on review of the totality of evidence. IMR was able to receive a methods checklist that was automated through a software program. This is an example of their checklist in which they basically had to answer yes or no and had comment boxes to flag any concerns related to any of the recommendations. So, step 1, the methods review included an evidence review and reporting. So evidence review completed by a single reviewer, and the reviewer must be without conflict in the topic under each review. Step 2 included evidence grading. Step 3 was a consensus grading, which is arbitrated by the IMR chairs, so each chapter had an IMR representative. A summary report went to steering, indicating agreement, discordance, and any arbitrary issues required. And this slide demonstrates some of the reporting that was available. Details of study and author group assessment of each study was outlined. The IMR process, verification, and assessment of the evidence was outlined. And detailed reviewer comments was also provided to contextualize what was actually concerning or discordant between the chapter's grading of the evidence and the IMR grading of evidence. One of the challenges for more information on the guidelines, please visit guidelines.diabetes.ca, where you will find the full 2018 guidelines as well as key messages, specific chapters that may be of interest for you, your patients, or your clinical practice, and patient resources. You can also download the Diabetes Canada Clinical Practice Guidelines app through Google Play or the Apple App Store, or you can reach the clinical practice guidelines through guidelines.diabetes.ca for healthcare providers or diabetes.ca for people with diabetes. You can also call Diabetes Canada at 1-800-BANTING for further details. Thank you.